Hi, everybody, and welcome to the webinar today. This webinar is on empowering communities, a way towards stronger health systems. It's part of a series that Emma is running called Health Management in Action, Fostering Health System Resilience. And these webinars are co-sponsored by the European Union. So we're looking at communities today, and so we have the great privilege of being joined by Ms. Caroline Costongs, who's the director at EuroHealthNet. She's an expert in public health, health equity and health promotion. It's nice of you to be here with us. Looking at the agenda, we have 10 minutes for me to do this very quick introduction to you. Then we'll have a 20-minute presentation from Caroline, and that'll give us 15 minutes at the end for discussion. So your Q&A is what we're really here for. So don't hesitate at any point to add your questions in the chat box, and we'll come to them live. And if at the end of Caroline's presentation you wanted to speak live, we really welcome that, because this is the place where we want those conversations to happen. So looking at to tell you a bit about Emma, so our vision is excellent health management for a healthy Europe. And we have a mission to support the spread of knowledge on effective health management, which is exactly what we're doing in this webinar today. And we live our values of excellence, quality, inclusiveness, relevance, and respect. And I hope you feel that, not just in this webinar, but in every exchange you have with us. Other things that are important about Emma is that we're the only membership organization in Europe that brings together the full diversity of the health management ecosystem. We're a recognized and respected amplifier of best practices in the evolution of health management, which is another thing I hope you'll see in the webinar today. And further to that point, we really like to provide an environment where evidence, challenge, and experience are valued, and complex debates on current topics can take place. So we're up for the debate, we're up for your questions, and I'd encourage you to really get engaged. And then finally, if you're not already an Emma member, I'd really encourage you to think about that. I know quite a few Emma members are joining us today. Thanks for being here and for your ongoing support. If you want to learn more about membership, check out our website. Okay, so let's come back to the topic at hand. So the series, to remind you, is Health Management in Action, Fostering Health System Resilience. And we want to discuss topics that are crucial to improve health system preparedness and response. And as part of that, we're thinking about what about community and working with communities. So we can drop our slides, and I'll hand over to Caroline. Who I think, Caroline, you're going to share your own slides, and you're going to give us a really great, interesting insight into what we can think about in terms of community engagement. Am I framing that right?
Yes. Okay. Thanks, George. Yes. So thanks a lot for having me here in this webinar series, and thanks to all of you being here with me. And I think it's important to see how we can involve communities better in our health governance and then health systems. And I'm delighted to talk you through some of our insights at EuroHealthNet. But maybe I'll start first with explaining a bit who we are and what we do. So we are a European partnership of mainly national public health institutes and regional health authorities. Also some ministries of health are part of our partnership, and some universities. And our main ambition is to reduce health inequalities in Europe, and in particular by addressing the underlying factors of ill health and disease. And as you may know, there are many, all in our living and working environments, education, and so on. We have 3 platforms where we work. We find it important to work with research to make sure that we work in evidence-based way. Practice is important to make sure that we learn from each other's methodologies and tools and how we can reduce those inequalities. And of course, the policy agenda is crucial, and we particularly liaise with EU policymakers and monitor European Union policies and make those insightful to our members in the countries. What I wanted to do with you today is first share with you some lessons from COVID, and then discuss more community-based health promoting health services, and then move into discussing how we can involve communities and what are mechanisms that we know of. In terms of COVID, the most important lesson for us is that COVID demonstrated an unequal impact across population groups, and it's often the more vulnerable people that have suffered more. So you can think about children, young people, migrants, people living in narrow, closed houses, homeless people, older people, people living in elderly care homes, a wide range of groups that have suffered in one way or the other, and it's also often due to the fact that the determinants of health and inequalities have interfered with the COVID pandemic, and also the COVID pandemic has widened inequalities and also ensured that there are some long-term consequences that many people feel in terms of increased poverty, or in terms of educational difficulties that is really, for some children, it's really difficult to reduce it, to solve these educational consequences of the school closures, for example. So it's really important to turn these lessons into strategies, that we do not forget that there are many groups in society that have suffered, and what can we do in the future. And one strategy that we can do much better is to systematically reach out and include views from these different groups into how we are dealing with health and disease and with pandemics. EuroHealthNet did a survey, a short survey with WHO, and we found that many governments did not structurally work with civil society or with people, community groups on the ground and bring their perspectives into how they tackle the pandemic. So we need to build capacities of government, how to do that, because it's not that easy. They need to develop their technical skills or methodologies how to do that. They need to improve their communication skills with reaching out to groups and people, and create really participatory spaces. It's about fostering social movements. And I think it's so important that I want to talk a little bit more about later. Because it all has to do also with creating trust in society, and trust can only be built if we work from the bottom up and with people and in co-creation. A second important strategy that we need to see included in preparedness plans is that there is a systematic assessment and mitigation of the collateral damage, let's say, of the response measures across sectors. And some people talk about the unintended consequences of our measures, but I think that is not taking sufficient responsibility of what we did. I think we should talk about collateral damage. As an example, the European Health Union, with the changed mandate for ECDC and with the HERA, is still very biomedical and do not take on these wider psychosocial impacts. We have seen in some countries that they did take this up, like in the Netherlands at RVM, one of our members, they set up behavioral and cultural insight units, so BCI units, and work with different disciplines to see how the public responded to the measures. Or providing mental health support. In Slovenia, they set up a task force with mental health actors and services to see how they can be helping during the pandemic, or generally empowering communities and boosting health promotion and disease prevention as part of health systems. This is very important because also health promotion and prevention is needed if we want to reduce non-communicable diseases and chronic diseases. And these diseases are also very much prevalent in older people and also in the groups at the lower bottom of the social gradient. So important to see how we can do that better. And how do we do that? So the shift to more community-based health promoting health services is one that we need to take, that policymakers and politicians need to argue for and decide that that is the way forward. And we do that by in three ways. One is to include principles of health promotion prevention as part of health services, hospitals, but particularly also primary care centers. Second is how health services can implement specific health promotion and prevention interventions. And the third one is how health services engage with health promotion and prevention in other sectors. So three ways, and I'll give some examples. In terms of including principles of health promotion prevention, you can think of being sensitive to the fact that some people have low health literacy and what you can do to address that. For example, the teaching back method is a simple way how that can facilitate and improve communication. Another one is the positive health approach. It is working, empowering people and working with the assets that they have and ask what matters to you rather than what is the matter with you. Or providing further advice on stress release or diet, physical activity, and so on. The second way is to have specific health promotion and disease prevention interventions. And here you can think of the more traditional, like screening, vaccination, checkups, smoking cessation, and so on. Preventative home visits are very important to reach certain groups, but you can also think of how health and well-being can be strengthened before a surgery, for example, in order to optimize recovery. Examples of the third one is already more difficult in a way because this is health services linking with other sector services regarding social need or addictions, substance abuse, mental health issues, but also working with urban planners in cities, how you can boost green spaces, promote physical activity, school-based health promotion, health and workplaces, active travel, and so on. So quite a lot that can be done, and quite some countries are now at national level thinking strategically, okay, how can we make this happen? One concrete example of how this can be done at the local level is social prescribing. And I wanted to give some examples of social prescribing because at EuroHealthNet, we held early in the year a country exchange visit in Portugal, in Lisbon, where we exchange ways and methodologies how social prescribing is dealt with in various countries. And this is all about making sure that non-medical needs that have an impact on health are being addressed outside of the health system. So by social services, for example, or by other community resources, and that there is a link worker. So someone in the community can be a social worker who helps with the connections to the different activities in the community. And this can also be related to arts or culture or nature-based solutions, for example. This is actually being done across the world. There is a global social prescribing alliance. And you can see here on the slide that the link worker is called differently in different countries, like community connectors in Australia, or well-being coaches in the Netherlands, or in the US, health lead advocates, community connectors. And it shows that there is a role for these professionals to bridge healthcare and social care and other sectors, and to be active there and help people. Quickly, to give you some examples how different countries are dealing with this. In Portugal, for example, in Lisbon, they are working with older people and migrants. You can see from the data that the majority are women, 67%, 40% is older than 60, 43% are migrants, 70% of the people they work with have chronic conditions, and 20% are overusers. So you can clearly see that this is a population that can be supported by other activities rather than by health services. In Slovenia is actually a great example, and there's a WHO case study here that you can read more about it, but they really have indeed a long tradition of health promotion centers that are part of primary care centers, very multidisciplinary and also linked to health insurance packages. And then in Hungary, they also have health promotion officers for a long time now, but they generally sort of lack some resources, human resources and financial support. In Italy, in Emilia-Romagna region, they have a certification system, so they certify sport facilities and gyms that GPs can use to refer their patients. In Austria, they have a national health promotion agenda, and they want to advance on social prescribing, and they are doing a pilot now. And very interestingly, they also include providing legal advice and career counseling to people. So it's quite a wide range of services. And they are currently looking into how to assess quality assurance and how to evaluate. In Finland, they have physical activity prescription since 2001. They have also arts and culture on prescription. And they do a pilot now, and they calculated that the average costs for a community of about 10,000 people is 33,000 euros for 60 to 80 referrals for social prescribing. And in the Netherlands, they now have well-being coaches and lifestyle coaches, so welfare coaches for older people, for loneliness and fall prevention, but also lifestyle coaches for people that are obese, and they can get support for sports, physical activity and diet, and these costs are reimbursed also by health insurance. And the interventions are accredited by the National Institute of Public Health. So various examples how we can use the community and activities in the community for health and well-being. And obviously this is quite new, so the evidence base needs to be further defined. More research is needed in the monitoring, in the quality control, how it is being financed, and also making sure that there are sufficient capacities in other sector services. So it's not about shifting a burden from health systems services to social services. I mean, they also need to be properly funded so they can indeed work with these clients or people. And children can be engaged more, and at all times you have to make sure that the services we offer are available and used by the hard to reach communities, as it is too often that they still do not take up the opportunities that are provided for them. In addition to social prescribing, which is one example, what is important is to make sure that we generally capitalize on the resources that are available at the community level. In a project that we did on Inherit, where we looked at sustainable and healthy actions, we found many innovative and great actions by citizen groups, by organizations locally, that are taking place. And we build a database of over 100 examples of these sort of actions. And generally, we recommend that local authorities need to embrace those actions and make sure that they are facilitated with some seed monies or with taking away some administrative barriers or legal barriers, that they can upskill their work, for example, help them with how to evaluate their actions. So there's quite a lot that we can do, quite some win-wins by involving what is already happening at the local level. And this will also help building trusts, which is too often a problem nowadays in our societies, and trust of citizens. And generally, I would like to say that we want inclusive health governance, working with citizens at all levels, which is important for trust and for making sure that we have our health policies and health interventions in better addressing the needs of people. So there are three principles that we need to take into account when we design ways of involving the community. And one is on inclusiveness. So this is about who participates and who decides who is going to participate. How can we make sure we get a diverse views from a range of groups across age, gender, socioeconomic backgrounds, cultural backgrounds. How can we work with multipliers who can reach out to target groups and can help communicating to certain groups? What are incentives for people to engage? So a lot of processes to think through. A second principle is intensity. And this is about how are the people involved, how frequent are they getting together, what do we want them to do, and influence. Influence is about to see how we can make sure that the decisions made in the participatory processes that they are taken on board in the interventions or in the policy design. And in that, we need to make sure that these participatory processes are meaningful, and we need to be transparent in what is what the reality is of the influence that they have, and make sure that we do not be over ambitious and raise false expectations, because that would, in the end, also undermine trust. There are three different levels of participatory work. One, for example, is in-person open for all forums where everyone can come and express their opinions. It's great to get a diverse range of opinions. Another way is to have more closed groups, smaller groups of specific people, for example, lay people or people from different socioeconomic backgrounds. And an example is here in Belgium, which is a group that I chaired. It was organized by the Belgian government. It was young people. So they brought young people together to discuss with them the EU priorities for health in anticipation of the Belgian presidency in 2024. And it was very nice to listen to young people and what their views are. So it's a nice example. Another example is in Scotland. You may have heard of it. This is the standard place tool. It is a tool that local communities can use to discuss the places where they live and how that can be improved. So really very focused way to discuss with citizens and to get their opinions. And the third way is to have more formalized mechanisms that has fixed seats. And an example is in Tuscany region in Italy, where they have a Citizens Council for Health, which is set by law. But also in France, they have the French National Health Conference, which is a body of 97 members, including different patient groups. Or in Portugal, they have the National Health Council of 30 seats. which is also nice. And in a way, it's all about addressing it's all about giving the people without a voice a voice and to give them some influence. It's about addressing the power imbalances that we see too often in our societies and to creating a safe space for people to give their perspectives of how we deal with matters. I'm almost there. I thought to also include a slide on technological ways of bringing in communities, empower communities to support the social prescribing, for example, but also to improve access to health services, to help promotion and prevention, which can help, but they can only help if they are designed and applied to meet the needs of the different groups facing vulnerability, of course, and also because they have the most to gain from these services. I won't go too much into detail here because there are all sorts of ways how that needs to be done better to make sure that we do not leave people behind. It's also about increasing digital health literacy of people, but also of professionals, so that they are sensitive to people with lower digital health literacy. And I wanted to share with you an example from one of our members from the Netherlands. They're called VAROS. It's an expert center dealing with health inequalities, and they also have defined 4 principles for e-health, that it needs to be clear, how you use with colors and make things attractive and easy to find and navigate. And they have developed a checklist for this, but also very much linking the digital solution with the face-to-face contact with professionals and also within local networks. So all important, I would say, if you want to reach out to communities in digital ways. Yes, one more slide or two, well, almost there. One more slide. This is how we work as EuroHealthNet in order to put this vision of health promoting health systems, of community participation. We work with a set of European Union initiatives and WHO policies and initiatives in order to achieve change. I won't go through them all, maybe just to mention that our member in Austria is hosting this WHO Collaborating Center, and they are currently drafting a briefing on health promoting primary health care, which is going to be finalized next year. There are also, next year, there is a WHO conference on primary healthcare in Astana, where we can put forward this vision in those debates there. Also at the Commission, member states are working on a health system performance assessment report, how to include prevention and health promotion into health system performance assessment methodologies. So a technical report, but potentially very helpful. The WHO is working on well-being frameworks. Generally, the economy of well-being or well-being economies is a very nice frame to change health systems to more holistic health promoting systems working with other sectors. The EU Conference on the Future of Europe is a big EU consultation mechanisms where they reached out to many citizens, and it closed in May, but they intend to organize a follow-up event this autumn still, I heard. And the Parliament is looking into all of the recommendations made and to see how they can be put into practice. I think some require a treaty change, and they had some strong recommendations for health, better health. The WHO Behavioral Cultural Insights Framework, very promising. All member states bought into this framework and will work with it. The digital health flagship of the WHO, as well as the digital health work of the Commission. The EU Recovery and Resilience Plans, which fund reforms in countries for different health systems, but also for more greener and healthier initiatives. And we are doing an analysis at the moment to see to what extent indeed recovery and resilient plans are promoting and contributing to health equity. DG reform, the technical support instrument, can be used for reforming health systems. EU Pact for Skills, a lot of skills are involved here, and the Be Well project is actually a project that George and Emma is leading, where we can look into this. European Health Union, I already mentioned. We will continue to advocate for more psychosocial approaches as part of the European Health Union. My very last slide, George, is just a summary, actually, of all the things that I discussed here, and I hope I didn't go too fast. Basically, it's about, in crisis responses, we need to always look at the social determinants of health, the broader factors, and engage with people out there that are most impacted. Secondly, it's the shift to community-based health promoting health systems. Third is that social prescribing is an interesting and promising approach to link other sectors with health systems. Fourth is we need to move towards inclusive health governance at various levels and get effective community engagement, also to build trust. Fifth is that technologies can certainly help, but we always have to beware of the digital health literacy and the digital exclusion and digital gaps. And sixth is there are a variety of policy initiatives out there that we can use to achieve change. So this was it, George.
Wonderful, Caroline. That was really fascinating. Thank you so much for that fantastic presentation. Again, I'd encourage the audience that we'll take your questions. You can put your hand up and you can switch your camera on and ask it live. If you're more comfortable just typing it into the chat, you're also welcome to do that. Caroline, you touched on many things, and I can see already a question's appeared. Denise, you've typed a question in. You're welcome to switch your camera on if you're comfortable. Otherwise, we can just speak to your question in the, there you are, Denise, welcome.
Yeah, thank you very much. I'm the Healthy Cities Coordinator in Cork City, and health inequalities is very central to the work that I do, and I feel very strongly about it. But I just posed the question there because it's one that I try to overcome on a daily basis in practice. I think health inequalities are frequently exacerbated actually by well-meaning policymakers who want to, improve health and go for low-hanging fruit options. I see it a lot in terms of lifestyle interventions. And I suppose the lifestyle drift, so maybe offering cookery courses in impoverished communities, or and then the people who access these services are the people who are well resourced, and you're actually exacerbating the health inequalities. I'm just wondering, Caroline, have you any advice how we can overcome that that way of working, or those kind of interventions that seem to be, in my world anyway, seem to be taking over a lot more at community level?
Yes, I agree on the lifestyle drift. That's something that we also struggle with. I mean, on the one hand, there are unhealthy behaviors that need to be changed, but we also know that they are driven by underlying factors like poverty, not having enough money, not knowing, and we need to make sure that there are policies in place to address that, to address the poverty but at the same time involving people from the private communities into activities is important, and working with multipliers, like working with teachers in schools in the private communities, or working with central figures in certain communities would be the way to make sure that people are on board. But this is one of the the most difficult challenges that we have in community participation. But it is very well possible. The problem is that it requires resources and time, human resources, because it is a matter of face-to-face work and contact. That's why I think that working with like well-being coaches or the link workers or the social workers is definitely a very good way forward. It's just that we need to have many of them in order to be able to do the outreach well and making sure that they are in touch with the ones that are needed the most. Yeah.
Well, thanks for your question, Denise. There's also a question from Gabby, who's joining us incognito from a cafe. It's nice to have you with us. And you say, do you have any insights in that Austrian health project? Is it government-based? Can you say some more about the Austrian project?
Yes, it is done by the National Institute of Public Health. I mean, they are involved and they are working with the monitoring and following it up. It is taking part in 6 primary care, but I don't have further details of. I know that the pilot is finishing up soon, but I know that they have a government strategy, the health promotion agenda. And they have set up 3 competency centers to look at health promotion, the future of health promotion, to look at health promoting health systems and health and climate. So their health promotion agenda in Austria is very, very comprehensive and direct, and social prescribing is one way they want to move forward. But the exact status of the project I would need to ask, but I can ask. I mean, yeah, we are in close contact. And this policy brief, we are also taking part in writing that policy brief, so that will be available next year.
Thanks, Caroline. It's clear you're doing some great work there. Glenn, he adds, do you see community empowerment as a general HP approach or for specific disadvantaged groups in society?
Well, I see that as a general approach, but as I had mentioned, the idea is to give voice to the ones that are currently not heard. And that is too often not sufficiently taken on board. Generally by local authorities and also by national authorities. You know, even the behavioral and cultural insights work in the Netherlands. They did a survey to know what people thought of the COVID measures, you know, but we know that certain groups do not participate in those surveys. They are not reached by those surveys, and they did some focus groups with the harder to reach communities. But generally it is difficult to get them because it takes extra effort, and this unfortunately too often these efforts are not being made sufficiently. Yeah.
And it seems to take a particular effort as well, not just extra, but it seems like a particular skill set. And you talked in your presentation about civil society being really an important players in that role, because I assume at a national level, the civil society organizations are best placed to connect to the communities most disconnected from the health system.
Yeah.
Would that be right? Is that the...
Yes, very much so. And what we saw in COVID and what also came out of our little survey is that the governments did not involve civil society organizations and organizations that are representing certain groups, you know, in their work. They weren't sufficiently consulted. They weren't structurally, systematically used. So that's why I do believe that we need to argue for much more for inclusive health governance in different ways, and to get it more systematically addressed, funded, resourced, and taken up, in particular in nowadays in our societies where we see polarization and lack of trust. And so we have to change how authorities need to change how to deal with that.
So, I mean, you've introduced a lot of elements, and in a way, like I feel like there's been a dozen chapters in your presentation, which has so well described the problem at large. And as I dive into that, I think about things like, even to Denise's point earlier around how do we get decision makers to listen to the evidence base when they have the challenges of ongoing elections, and popularity has become a factor in health decision making. So that's one thing on my mind. The other thing on my mind is around thinking technically of the role of health managers. Health managers really sit in the middle of that position between where legislative decisions are made, where service is provided, and in the middle there you have health managers coordinating services, doing leadership, doing governance, and what roles can they be playing? Would you have any advice, Caroline, like your top tips for health managers in their roles?
Well, I think health managers are the professionals who should be able to work on this, because many of the health professionals themselves, they are busy with, you know, with what they always do, and it is sort of easy to say, okay, the GPs now need to prescribe socially, and they now need to include advice on this, that, and the other, because they don't have the time, and we can only, health professionals will only change and work on prevention and health promotion if they are enabled to do so, if they have the time to do that, if their funding structures or financial incentives are in such a way that they can give that kind of advice, and they can consult with or reach out to other sectors. And it is the job of health managers to make sure that they have the space to do things differently, and they have the time to do the outreach visits, or to have focus groups. Or I heard this nice example of a doctor that he's doing walking groups. Once a month he takes his patients out for walking tour where he works with them, which is really very nice idea. But you know, you need to be able to create spaces, and I would say health managers are the ones that need to advocate towards policymakers and support and create and enable health professionals to do the work more prevention and promotion. So in that sense, George, I'm delighted that as Emma, you are looking into this and are open for this, because I think this is the health system for the future, and it's health managers who are pivotal to make that change, or to help make that change.
Thanks, Caroline. That's a great note to end the webinar on. Your work is really welcomed, and we appreciate you collaborating with us to present at the webinar today, to help share the really great work that EuroHealthNet are doing. And we look forward to ways that we can keep up this conversation and keep this work going. Like you said about prevention, it's important and it takes a long time, but it's worth doing. In the chat, you'll just see now a hyperlink to our survey. We do this every time. It takes me more time to describe the survey than it takes to answer it. It's 90 seconds just to get your quick views on how today went. And we use the survey routinely. It helps us shape the speakers. It helps us come up with new ideas. So please do take 90 seconds to fill that in. Our next webinar is about towards a better EU for health preparedness and response, looking at gaps and solutions. And that's going to happen on Thursday, the 3rd of November. So if you're not already registered for that, we'd love to see you there. And otherwise, I just want to thank you. And Caroline, I want to thank you again for just your generosity and for being with us today.
Super, and thanks to you as well. It was very nice. Thanks.
Thanks everyone for attending. Take good care, and we'll see you next week.